Welcome everyone to this afternoon's Foundations curriculum as part of the neonatal hemodynamics curriculum talk. We have a fantastic lecture planned for today. We do have a few just housekeeping things beforehand. I just want to acknowledge that the Neonatal Hemodynamics and T&E Foundation's curriculum is supported by an unrestricted educational grant from Pharmaceuticals, so thank you to them. And as a reminder, we now have accreditation as a self-approved group learning activity by the Royal College of Physicians and Surgeons of Canada. So I'm going to start off by introducing one of our speakers today. Dr. Michael Castaldo is a staff neonatologist, the neonatal transport lead and co-lead of the T&E program at BC Women's Hospital in Vancouver, and is a clinical assistant professor at the University of British Columbia. We're excited to have him speak today, and as a reminder, we do have our next lecture in the December is a special session, so we're excited for that on the competencies, collaboration, and program growth. Dr. Castaldo, we're really looking forward to your talk today, so you can take it away.
Thanks, Amy, and thank you, everyone, for affording this opportunity to myself and the entire team in Vancouver. Now, full transparency, the star of the show today is going to be Dr. Uthaya Kanagaraj. He is not unfamiliar to many of you in this forum, but it comes with immense pleasure that I'm introducing him now as in his new role as a staff neonatologist with TNECO training, and he will be navigating today's lecture. Just to give you a little bit of background about Uthaya, he completed his medical school and pediatric residency and his neonatal fellowship in India. He jumped over to us about 4 years ago to do the program fellowship here at UBC, and he completed his targeted neonatal echo fellowship just this past year. He holds a graduate diploma as well in clinical epidemiology, which he was able to obtain from McMaster University. I can't say enough about this individual. He's an incredible contributor, not just to the TNECO team, but holistically, he has just brought a lot to improve some of the processes that we have here in Vancouver. We're excited about what he's able to do going forward as it relates to the hemodynamics. And he's also, from a personal point, become an incredible friend and introduced me to the wonderful sport of cricket, which you'll see a little bit later. But without further ado, I'm introducing you to Uthaya. Uthaya, take it away.
Thank you, Dr. Castaldo, for the kind introduction. Without wasting time, let's move on with BPD-associated pulmonary hypertension. So we all know it is, it's the importance of BPD-associated PH. So we'll go through that, and subsequently we'll go through some of the cases along with pathophysiology, and finally some management, including evidence base. So BPD-PH is a multifactorial contributing factor, starting from antenatally, IUGR, placental dysfunction, hypertensive disorders, diabetes, and PPRIM, as well as postnatally. It leads from infection, hyperoxia, inflammation, and hypoxia as well, affecting the developing lung circulation, causing abnormal structure, abnormal pulmonary and cardiac function, as well as decreased growth. This is essentially important to know because it starts with functional changes with high vascular tone and vascular reactivity, which is a time we could intervene and get the baby reverse. If the pulmonary pressures goes on to develop, it goes on to changes to an structural changes. We have a fixed component from a dynamic component, and from there the chances of recovery would be very, very slow or delayed. So the risk factors you see here are almost same as for BPD, which is similar to BPD-PH as well. And from the literature review of BPD-PH, infants with BPD, like moderate to severe BPD, around 3 to 44% develop BPD-PH. And the mortality rate has been reported anywhere between 14 to 38%. Also, there is higher morbidity, including longer hospitalization, longer ventilation, higher ROP, higher need for respiratory supported discharge, and higher tracheostomy in those babies who had a BPD-PH. So there is definitely a higher burden, and there is definitely a pressing need to address BPD-PH at this point. This is our local data over the last 10 years. The incidence of BPD is between 40 to 60%, and the home respiratory support need over the last 10 years was around 12% in infants less than 29 weeks in our unit. Of this, around 50% needed low flow oxygen, and 40% went home on CPAP, and remaining 9% needed tracheostomy. Interesting to note, infants who went home on tracheostomy, almost 90% had had higher incidence of PH compared to 40% with CPAP group and 17% with oxygen group. And this is a nice graph depicting the importance of earlier screening. So the x-axis shows the age in months, and the y-axis shows the infants with PH in percentage. So to start with 100%, and then the mortality is very severe in the initial days. And as it progresses, there is a gradual improvement. So it is very essential to catch the infants before they go into a severe PH or going to a fixed component. So we know now there is the importance of BPD-PH. So what are the clinical features? How would they usually present in preterm babies? So we'll start with some cases. I'll present 3 cases and then we'll go through one by one. To start with case 1, this is a 25 plus 5 weeks, 700 grams, one of the monodied twin. No treatment received for PDA. Around 32 to 34 weeks, PMA, the baby had excessive weight gain without linear growth and some edema. The blood pressure is around 50th centile, currently on non-invasive NAVA support with PEEP of 8, FIO around 30%. Moving on to case 2. This is a 23 plus 3 weeks, 530 grams, received medical treatment twice for PDA and received dexamethasone for evolving severe chronic lung disease. Now at around again 32 weeks, currently still on the respiratory support, higher respiratory support, non-invasive support, no improvement in respiratory status with FIO around 40%. Interestingly, the blood pressure is higher, around 95th centile. Case number 3 is a 24-weeker, now 627 grams. At birth it was 627 grams. Initially had early PH, needed vasodilators, pulmonary vasodilators for the initial 1 to 2 weeks, and then received a medical course of treatment for PDA. Also received a course of dexamethasone for evolving chronic lung disease. Now at around 32 weeks, sudden severe desaturation spells, but recovered very slowly with oxygen. The BPs are around 50th centile. Again, the non-invasive support is around higher side, 20 on 10, with FiO2 around 40 to 50%. If you look at these cases, more or less, they look almost similar in features, like they have similar NIV settings. So these babies have been these babies are consulted by us, like a team, to evaluate for pulmonary hypertension at this point of time, as they were concerned about elevated pulmonary pressures. Now we go into each one by one, the echo of these cases. We do a comprehensive evaluation of all the important images, including assessing RV-LV function, pulmonary pressures, evaluating the shunts. But for simplicity's sake, I'll present like few slides, few images or few clips to show the importance. So case 1, as you see here, is a subcostal view showing an left-right shunt across at the atrial level shunt. And here an apical four-chamber view showing a dilated RARV, and you could see the septum defect. And there's a short axis view here showing LV and the RV on the top, dilated RV, the septal flattening both in diastole and in systole. It's case 1. Moving on to case 2. So as you see here, the dilatation which we saw in the other echo with RV doesn't look that. RARV looks fine. LV looks okay. LA may be dilated. We look at a color Doppler, we get a MR or a mitral insufficiency. I will look at the septum, have a rounded septum, unlike the other infant. And here we see some of the LV function markers, the diastolic function, and IVRT of around 70, and the pulmonary vein, you see a reversal of the A wave, and LA ratio is dilated is around 2, without any evidence of fetal shunts at this point. Case number 3. So here a short axis view showing the septal flattening, and apical foot chamber showing RARV dilatation, putting a color Doppler, we get a TR jet showing elevated RVSP, and a pulmonary artery Doppler showing a sharp PAAT, and the PAAT RVT ratio of 0.18. No fetal shunts are present. So when we're looking at across the septum, though the clinical features look similar, when we look at the echo features, they are entirely different. One with dilatation, with due to flow-mediated atrial shunt. Second, and probably due to a post-capillary PH without any evidence of pulmonary vascular resistance. And third case is a primary PH without any shunts or any LV dysfunction. So let's dive deep into each cases. What is going on with each and which with the physiology. So if you look at the flow-mediated PH, the case 1, there is a left-to-right shunt causing more blood going into the RARV, causing RV volume overloading and dilated RARV, which in turn increases the blood flow to the pulmonary circulation, causing pulmonary edema. If it persists, the shunt persists, it could lead on to pulmonary vascular remodeling. Similarly, if you have a PDA persistence, and rarely we do see some aortopulmonary collaterals causing increased blood return to the left side of the heart, causing more blood entering the left side, dilated LLV, pulmonary edema, and if persistent, leading to pulmonary vascular remodeling. So what are the echo features you would see in flow-mediated PH? We all know about PDA. There is an increased blood return to the left side, so you might see an increased pulmonary D wave velocity, dilated LA, could see a pseudo-normalization of the EA ratio because of volume overloading. And for similar reasons, there will be short IVRT, dilated LV could be there, LV output would be increased. And also there will be a systemic steal. You might see a whole diastolic flow reversal in descending aorta, or an absent or reverse and diastolic flow in SMA and celiac. Similarly, when you come to AST, there are not much of literature or any certain echo markers to say which is clinically significant. So based on the pathophysiology, it could be you might see an increased pulmonary D wave velocity because of increased blood returning to the left atrium. Dilated LA could be there based on how well is your LV relaxing based on that, and could be dilated RARV. Sure, you might see, as you see in our case, and septal flattening at end diastole indicating volume overload rather than a pressure overload, and could be a high RV output, and systemic steal is unlikely here. Moving on to post-capillary PH. So the pathophysiology could be, as in our case, there could be a systemic hypertension, or sometimes even with elevated blood pressure, even with the blood pressure is normal, some intrinsic impaired LV relaxation or restoring forces could lead to decreased LV filling or increased LV and diastolic pressure, causing increased LA pressure in turn, leading on to pulmonary venous congestion and pulmonary edema, causing pulmonary, if it is persistent, go on to lead to pulmonary vascular remodeling. So what are the features, again, you would see by echocardiography? These are some other markers. Again, the evidences I will review briefly later. If you think about the pathophysiology, starting with if you have a high systemic blood pressure, you might see an aortic insufficiency, but may not always. If it is a chronic baby receiving multiple courses of steroids and high blood pressure, you might see a thickening of the ventricular septum and ventricles. And because of high LV decreased LV filling, you might see the flow across the mitral valve will be dependent on more on the atrial contraction rather than on the early filling phase. So you might get a decreased EA ratio as well as prolonged IVRT. You might see a mitral insufficiency. LA could be dilated in the absence of any shunts. Sometimes you might see a pulmonary A wave reversal in the pulmonary vein Doppler, and it could be a prolonged duration. Pulmonary insufficiency if it's severe and goes on to have TR jet or septal flattening and systole as well. So I'll briefly go through the literature review because it's again, it's really an important area to discuss. Before 2008, there were some studies talking about LV diastolic dysfunction in preterm infants, but it's actually when in 2008, Dr. Morani and colleagues published 2 reported cases of post-capillary PH confirmed by echocardiography with post-capillary wedge pressure more than 12 in BPD infants, and they correlated with myocardial performance index or TI index being high, signifies post-capillary PH. And then again in 2016 by Dr. Shegel from Australia, he reported LV diastolic dysfunction in 20 infants with BPD compared to infants with a BPD. And he found out these parameters like mitral valve VA ratio, IVRT, mitral valve stroke volume, and myocardial performance index to be significant markers. If you are like some of you might not be aware of these markers, but do not worry about this. It's important to know about the concept and the importance. But for the TNE fellows who are here, if you are interested in this, then you can listen. If you have any doubt, please feel free to ask me. Bukinik again in 2017 mentioned about LV diastolic dysfunction. This is a study from Poland in 82 preterm infants with BPD, and they mentioned mitral valve VA ratio and E prime as significance in infants with BPD, and other parameters also they have evaluated. And Dr. Shigel again in 2018 published a case series and where he used AC inhibitors in post-capillary PH and infants with high blood pressure and showed some improvement in echo markers as well as improvement in clinical parameters. He also measured these parameters associated along with those he earlier documented. Dewall et al. From Australia in 2019 is one of the stalwarts in diastolic function assessment. He described diastolic function in preterm infants less than 30 weeks. And he, based on the AAC recommendations from pediatric and adult guidelines, he evaluated these 5 parameters, including LA volume index, EA ratio, mitral E prime, EE prime, and TR jet, and signifies and classify the diastolic dysfunction in preterm infants. As we move along, this is from one of our moderator here, Dr. Stanford from Iowa, published a case series of 11 infants, use of AC inhibitors in systemic hypertension. They have mentioned improvement in IVRT and LSA as a significant between those who received AC inhibitors without those. This is Rigotti from 2022, published a paper about LV function markers in infants with BPD, and they found out EE prime ratio more than 12 is associated with longer respiratory support, oxygen needs, and higher BPD rates than infants who had EE prime ratio less than 12. Dewall et al. Again evaluated the association of early respiratory disease with diastolic dysfunction. He showed low LA strain, and he measured the similar parameters, and he defined diastolic dysfunction 3 out of 6 parameters being abnormal to classify this as a diastolic dysfunction. Again, this is a study from CHOP mentioning evaluating infants who underwent cardiac catheterization and classified post-capillary wedge pressure more than 10 as post-capillary PH. These infants had higher tracheostomy, higher BP, and higher systemic vascular resistance. And they haven't found any difference in echo markers between elevated and normal pulmonary capillary wedge pressures. This is a study from Singapore in 2025, similarly showed prolonged IVRT and higher MPI associated with severe BPD. This is the latest one from Iowa, evaluating 64 infants with BPD and finding the association between systemic hypertension and LV diastolic dysfunction. They priori classified more than 90 millimeter of mercury systolic BP as systemic hypertension, and they found out these markers are significantly associated with systemic hypertension. Moving on to case 3, from post-capillary to pulmonary arterial hypertension. We all know the pathophysiology here. If you have a high pulmonary vascular resistance, the the normal RV started to get stretched up. It goes on to have a hypertrophy, what we call a homeotropic adaptation, where the contractility increases and to improve the RV output. But if it persists, the RV pressure or the pulmonary vascular resistance persists, it go on to develop RV dysfunction or RV dilatation, causing RV failure. The problem here with preterm infants is they don't well adapt, so they might usually skip out the phase of homeotropic adaptation would be less, so they go on from normal RV to RV failure much sooner than in an adult or pediatric population. The echo parameters we all well know. So you will look at the pulmonary arterial pressure. For pulmonary arterial hypertension phenotypes, you might expect a TR-jet, but at this station you might not see. Septal configuration is mostly we rely on. So objectively, you can measure LV eccentricity index at end systole, more than 1.3 being mentioned as significance. You can measure a PI if it is there, or a transductal right to left peak flow velocity you can measure. And pulmonary vascular resistance, you will look at the pulmonary artery acceleration time. If it is small or less, it is significant. And the PAAT-RVET ratio, pulmonary artery acceleration time over right ventricular ejection time. If it is again lower, less than 0.25, it is significance. Or you might see the pulmonary arterial Doppler. It could be a right angle or it emits systolic notch. And you would be worried about right ventricular function. You would be looking at that. You look at TAPC, FAC, RV output, and tissue Dopplers. And if it is impairing her RV, then you will be looking at LV because of the ventricular interdependence. And you'll also look at shunt direction across PD and PFO if at all present. So we all know about the Hagen-Poiseuille's law, which is flow is change in pressure over resistance. And rearranging this equation and applying to the pulmonary circulation, we get the mean pulmonary arterial pressure is equal to pulmonary blood flow times pulmonary vascular resistance plus pulmonary capillary wedge pressure. So the pulmonary vascular resistance could be due to maladaptive, as happens in our patient population with chronic lung disease, or pulmonary hypoplasia, or in a UGR, or mal-developed like in alveolar capillary dysplasia, or surfactant deficiency, or in trisomy 21. Our pulmonary blood flow could be due to shunting across left to right, like PDA, AST, VST, or AP collaterals, or due to pulmonary capillary wedge pressure could be due to LV dysfunction, systolic hypertension, or due to pulmonary vein stenosis, which is an emerging topic. These are the reasons. But as you see, this is a spectrum. This is not one phenotype. These are not individual phenotypes. So each parameter is interdependent. So the pulmonary arterial pressure is dependent on pulmonary blood flow as well as pulmonary vascular resistance and pulmonary capillary wedge pressure. So in other words, these phenotypes are not mutually exclusive. So you could see these phenotypes in the same patient population. So we may have to differentiate which is a predominant phenotype and you have to go from there. And if you look at the pathophysiology of BPD-PH spectrum, whether it's a pulmonary vascular maladaptation or PAH, or flow-mediated, or if it's a post-capillary causing pulmonary venous congestion, it leads on to increased hydrostatic pressure, either due to pressure or volume overload, leading on to alveolar or interstitial edema, causes increased extra-alveolar pulmonary vascular resistance, which in turn increases the pulmonary hypertension. So this is a vicious cycle. And if it goes on, it impairs your, it again, as you saw, it impairs your right side of the heart. So we need to break the cycle. So this helps in preventing the progression of pulmonary hypertension, gives a symptomatic relief to the patients, as well as reduces the stress on the RV. This is not a definitive treatment. This is just a symptomatic to prevent the progression of disease. So diuretics would be helpful at this point to prevent this. Again, so we have seen all these phenotypes. Why it is important to differentiate these phenotypes. So let's talk through our cases. So we have a flow-mediated PH. In this, would you consider diuretics? Yes, I might, I would, I will. And shunt closure, if diuretics We have maximized, given a diuretic, still the babies have a significant shunt. Yes, if you have a significant PDA, you would consider shunt closure. Pulmonary vasodilators, yeah, which might worsen here. There is a PDA or an atrial shunt. You might be having worsening pulmonary, you might worsen this condition. Similarly, if you have a post-capillary PH, you might consider diuretics. As you know, you have a pulmonary venous congestion. If you have a systemic hypertension along with it, even after diuretic it's not improving, you would consider antihypertensive. Pulmonary vasodilators in this patient population would not be ideal, as it might worsen the condition. So you move along with pulmonary arterial hypertension, you would consider again diuretics would be helpful to stop the flow. Pulmonary vasodilators, yes, here it would be helpful. So it is essential to differentiate these phenotypes so that we can institute appropriate treatment. Before moving on to the management, it's essential to address the comorbid conditions. So the high pulmonary arterial pressure, this has been nicely illustrated by Dr. Steve Abman in the latest paper. The not only the LV or RV function or the shunts and the pulmonary vascular disease, it is also dependent on airway disease and the lung disease. If you have a reflux or an aspiration or a tracheobronchomalacia or an subclottic stenosis, it could impact the pulmonary arterial pressure. Similarly, if you have a hyperinflation or atelectasis in the same picture as we all know with a severe lung disease, it could impair your pulmonary vascular resistance. As you know from this graph, if you have a low lung volumes, your extraalveolar PVR would be high. Similarly, if you have a hyperinflated lung, you will be having a high alveolar PVR. So you need an appropriate functional residual capacity lung volumes to maintain your PVR at the lowest level. So you would consider simultaneously working on if the infant has similar any of these comorbid conditions, you'll work on this along with working on the diagnosis of pulmonary vascular resistance. If we talked about echo, I'll touch upon the cardiac catheterization later as we move along. So management perspective, I'll consider supportive care, which includes nutrition. Fluid balance is important, so you don't want excessive fluid or maintain an appropriate fluid, adequate calories. Ventilation, as we know, hypoxia and hypercarbia are worsens your pulmonary vascular resistance. You need an appropriate hematocrit and evaluate and address the comorbid conditions as we see in the earlier slide. So moving on to pharmacotherapies, you have to, diuretics is an option, but it's not the primary effective treatment across a particular phenotype. You need to define, you need to look at the various treatments available like pulmonary vasodilators or AC inhibitors. Pulmonary vasodilators includes PDE4 inhibitors like sildenafil, endothelin receptor antagonists, prostanoids, and inhaled nitric oxide as a rescue therapy if you have an RV failure. Let's look at the evidences behind each of these as we move along. So diuretics in chronic lung disease, we all know. There is a Cochrane review published in 2011, which mentioned chronic administration of furosemide improves both oxygenation and lung compliance, but they do not recommend diuretics at that point based on the available evidence for chronic lung disease. Okay, so what are the evidences of diuretics in BPD-PH? This is one of our work. It's in the process of publication. When we looked at the literature, there are no RCTs exist on diuretics in this patient population for BPD-PH. Evidence for critical outcomes is really lacking. There are a few observational studies showed some improvement, as you see here, improvement in PAAT and improvement in TAPC, which is a function of RV function, and PAAT is a function of pulmonary vascular resistance, you might see. But diuretics cannot be recommended at this point based on the available evidence. So we need a high collaboration with other centers across the world to need a high well-designed trials to define the role of diuretics, whether it's actually beneficial or not, though it's physiologically seems appropriate, whether it's useful in by evidence based. When you look at sildenafil, there is a systematic review or a meta-analysis of sildenafil in BPD-PH published in 2019. Based on 5 retrospective studies, the mortality rate was around 29% per year, and they showed some improvement in pulmonary arterial pressure and respiratory scores. But again, based on 5 retrospective studies, currently 2 trials are underway involving sildenafil. What about other drugs? When you look at the second-line drugs recommended by most of the guidelines after sildenafil is bosentan, which is an endothelial receptor antagonist, and mostly based on observational studies. And prostanoids are also being recommended as third-line or an adjuvant treatment, but again, based on observational studies, no approved treatment available. What about AC inhibitors? AC inhibitors inhibits replacement of elastin by collagen. It inhibits release of increases the release of vasodilators like prostacyclin, nitric oxide, and prostaglandin E2, causing vasodilatation and decrease intimal thickening. Also improves endothelial dysfunction and increase angiogenesis. We'll look at the evidence as we saw here earlier briefly. Couple of centers have used enalapril, and we have used in a couple of babies in with system hypertension and LV diastolic dysfunction. Have shown improvement in LV diastolic function parameters and reduction in oxygen and ventilator parameters has also been noted, but this needs to be studied further. So guidelines from various societies. So obviously, yes, we do not have much evidence. So this is a very, very important work across the world to putting in consensus-based guidelines from Pediatric Pulmonary Hypertension Network and from European Pediatric Pulmonary Vascular Disease Network and American Thoracic Society and American Heart Association, and also from European Society of Cardiology and European Respiratory Societies, though there are subtle variations between their the guidelines and the flow chart. More or less, they recommend suggesting screening at around 36 weeks based on the severity of BPD. If you have a moderate or severe BPD, suggest echocardiogram defined based on the pH based on echo into mild, moderate, and severe. And for severe, suggest medical treatment to start with pH-specific drug therapy, sildenafil mostly, and second line as bosentan. And some suggest cardiac catheterization before pH-specific drugs. Some after the first line, if there is no response, to evaluate LV function, to evaluate the pulmonary vein stenosis, as well as for the shunts. They also suggest follow-up, and NT-proBNP as a marker has also been suggested. But for me, I feel like if you're screening at 36 weeks, we might miss infants who are having these symptoms earlier and missing identifying. We know that earlier identification is critical to prevent the mortality which happens in the initial few days of or few weeks of diagnosis. So we need to screen much earlier, like around maybe 32 weeks or earlier. I don't know the answer, but I'm thinking we need to work on this. And we need to specify this phenotype specific classification here based on the echo so that we could institute appropriate treatment rather than blindly using pulmonary vasodilators for all the patients labeled as pulmonary hypertension. So this is a proposed physiology-based approach. So we are working on in our unit to kind of similar framework. We haven't completely finalized it. This is just proposed approach. So infants born less than 28 weeks, 1,000 grams, suggesting screening echocardiograms at 32 weeks or earlier If any of these following symptoms or parameters are present, like infants definitely needs to be on descending pressures or supplemental oxygen, and having unexplained worsening of respiratory status following a period of improvement, and lack of expected improvement in respiratory status, frequent hypoxemic episodes, and symptoms of heart failure or elevated systemic pressures. These infants needs to be screened. And based on screening echo at the initial time point, define BPD-PH. If there is no BPD-PH, then review every 2 to 3 weeks until the infant is off respiratory support. However, if you find, then you need to classify it. And diuretics is the first line to break the vicious cycle of pulmonary edema worsening pulmonary congestion. And you follow up in 5 to 7 days. You see clinical and echo markers for improvement, and if there is no improvement within a week, then you reassess the infant and reconfirm whether it's the same, or is there any associated comorbid conditions. Address that before moving along to the next second line options, which I will discuss subsequently. But if you see an improvement at this time point of 5 to 7 days, you can't continue diuretics until the baby is off respiratory support, because we have seen improvement, and follow up echo to see every 2 to 3 weeks the infant is trending in the right direction until the infant is off respiratory support. And if yes, then you would discharge home without diuretics, take off the diuretics, see the infant and send them off. However, the infant has to go back on respiratory support, suggest to send home on diuretics. This is infant with probably mild to moderate. If it is severe, then second line options we'll discuss. So the phenotype proposed phenotype based suggestion would be like AC size 2 mm. This is just an arbitrary number. If you have this number along with the features of RV dilatation or IRV output or RV volume overloading or an RV function, you would consider diuretics. You could consider this. And if you have a PDA size more than 1.5 still having at 32 weeks or earlier, and having significant impairment on the LA, LV, like a dilated LA, LV output is high, or having systemic steal, then you consider systemic diuretics, or depending on how much severity, you might consider shunt closure. Post-capillary markers, as proposed by Dr. Duvall in his paper, taking not only single parameters, taking multiple parameters and taking like say 3 or 4 parameters out of whatever we have, could be a one marker to suggest as a LV diastolic dysfunction with diastolic heart failure to use diuretics. And along with, you can use other parameters such as clinical features of generalized edema or fluid balance, which we usually in our practice, we look at the fluid balance growth, whether they're growing just edema without any linear growth, or we also assess the pulmonary edema by lung ultrasound to classify diastolic heart failure. And for pulmonary arterial hypertension, you could diagnose PH by one of the following, either PDA shunting right to left, or bidirectionality, or objective evidence of LV eccentricity and systolic index more than 1.3, or an RVSP if you have more than 36 plus right atrial pressure. Plus, if you have right atrial dilatation or a significant PVRI, the PVR index, like less than 0.25, you could consider starting diuretics, which has been shown from a lot of, which has been used, this approach has been used is being used in across the centers across Canada. The second line options for flow-mediated, if no improvement in diuretics, you would consider shunt closure and discussion with cardiology. For post-capillary PH, no improvement with diuretics for diastolic heart failure, you would consider AC inhibitors if you have an systemic hypertension, and you might have to confirm the post-capillary wedge pressure with the catheterization and consultation with cardiology. And PAH, no improvement with diuretics, you might consider sildenafil if it's an isolated or primary PAH. And if no response, you would be considering, again, catheterization to rule out any pulmonary vein stenosis, again, left heart function. Hence, we suggest, we call for collaboration with other centers across the world for earlier screening, having some standardized approach to create more evidence, to have to prevent the development of moderate to severe BPD and prevent the mortality and morbidity of these extreme preterm infants as we caring for more and more small babies like 20 to 21 weekers. And it's again validate multi-center collaboration to validate the phenotype-based classification or echo markers to help guide individualized therapy, especially in the context of limited evidence. And I'll stop here. Thank you, everyone, and I'm happy to take questions. And I'm really thank you for my team, Dr. Castaldo and Dr. Mitra. And this is one of our pictures showing when we watched the cricket, and I introduced our cricket to Mike.
Thank you very much for that wonderful talk. I'll remind our attendees to go ahead and put your questions in the Q&A box. But while we wait for some of those to come in, like I said, excellent talk. One of the things that I find most difficult is it seems like some of our patients have both evidence of resistance-mediated disease on their echo as well as a post-capillary phenotype. So can you talk to us about how you go about teasing those things out when as you've so eloquently discussed, pulmonary vasodilators can fix one of those things and make the other physiology worse?
Yeah, this is a very common scenario we see in our echo when we are reviewing the echo. It's really difficult to delineate. So what we do is like seeing which phenotype is predominant. Like sometimes you might not see that RV dilatation. You might see some evidence of raised PVR, but you could see most of them due to flow mediated due to atrial shunt. Then we would say, yeah, it's most likely due to flow mediated, and we would start with diuretics. If no improvement at that point, then then again we would consult with cardiology. Similarly for the post-capillary as well, it's really tricky to differentiate these both. Uh, and looking at the parameters, if you have multiple parameters, multiple echo markers to say which is coinciding with post-capillary or to PVR, then we classify them as predominantly this phenotype and then institute appropriately. So to say if you have a post-capillary component, we would not consider starting pulmonary vasodilators in this patient.
Thank you. The other thing, I don't know if you have run into this, we're clearly seeing signs in these patients where it's not resistance mediated disease, but sometimes specifically with, flow mediated disease with ASDs. And how do we kind of bridge that gap with our cardiologists? Because I feel like we frequently see these babies who don't have very large atrial level communications, but they're clearly causing them issues. And then when we try to loop in our cardiologists, they're not quite understanding that this small defect can have such a big impact. You mentioned starting to screen these babies, earlier at 32 weeks. A 2 millimeter, 3 millimeter defect could have a really big impact at that point. And so I'm just wondering how you guys go about liaising with your cardiologists, because what we sometimes see is we'll start the baby on diuretics, and then as they're getting closer to discharge, then cardiology gets involved for the atrial level communication, and they say, oh, the baby doesn't need diuretics, come off, and then the baby gets worse, and we kind of get stuck. Who's going to follow these patients long term?
Yeah, exactly the same situation here as well. Like we struggle with this. Like we have multiple conversation with our cardiology colleagues related to that. And recently I had a talk with one of our cardiologists, and they seems like they agree that it's causing issues. These babies need a longer respiratory support. I think it's need more time and more convincing with them, and they need to be more uh, I think they said the weight cutoff as like they say, like if it is 8 or 9 kilos, they would be considering closing, which we don't see in our patient population, which is a huge long time. So we need that expertise and this so someone need to bring in to think about closing this earlier. I would say it might take some time, but these babies surprisingly do usually well with diuretics. If you compared to other phenotypes, these patients does well when we start diuretics. They get better much sooner, and they might need diuretics for longer time. So we usually send them home. And diuretics, again, follow-up is really difficult. we send them on diuretics, and it will be followed by cardiology.
Yeah, it's hard to sometimes sit and watch these patients while they're still in the hospital and knowing, say that, like you said, the diuretics work a lot of times, but in sometimes are not. And then you worry, are we just going to be causing more problems down the line with, pulmonary overcirculation, eventually leading to resistance-mediated disease? So, like you said, I think this is a big area that we need to continue to work with our cardiology colleagues to kind of get them to realize that. I think that's not an insignificant portion of our patients who we're seeing have these issues. And it looks like Mike has his hand raised.
Amy, I think it's such a good point that you're bringing up, and it's something that has evolved over my years of being fortunate. Sorry, I'm on service. 2 seconds. Seeing it evolve and seeing the collaboration become stronger with cardiology, we're seeing identifying, stratifying babies that are more at risk, be it an underlying intrinsic condition being T21 or any of the other factors that Uthaya highlighted. But now we're at a point where we're screening and identifying these babies who don't necessarily need to be inpatient, can be managed with a solid long-term plan from a surveillance point of view that includes anybody who's going on any medication, be it diuretics, but also any patient that is going home with home ventilation or supplemental oxygen. That is a baton that we need to hand over with an agreed upon plan. So we're starting to get that partnership, that collaboration is so necessary to make sure we're not waiting too far along before this baby is looked at again by cardiology. But it's not perfect, but I do value the fact that we're now stratifying the patients that are more at risk, secondary to everything that you and Uthaya have just highlighted. So moving forward, hopefully there's much more of a long-term surveillance that perhaps as we build out our staffing is much more partnered with cardiology and the T and Echo team, which I think is so important because of the holistic approach that we bring to the table as well.
Agreed. Final question, you brought up with the post-capillary phenotype in terms of, the LV diastolic dysfunction. In your kind of reviewing all of the literature, it seems like this is something that we're learning more and more about in the last several years. Do we think we're going to find something that is making our certain infants like predisposed to this? Do we think it's the more steroids we're using or anything else that comes to your mind that you could think of that's kind of showing us that this is not a benign disease pathology that we're seeing?
Yeah. Uh, I feel like we were discussing before, there are certain uh, uh, patient population we feel they're more prone to get this post-capillary. One, as you mentioned, steroids and multiple courses of steroids. And second one, for some reasons, they have some systemic hypertension. I don't know, is it because due to the pulmonary vascular remodeling could happen in the systemic vascular level as well. That could be one of the reasons, could be. And the third set of babies we see is those babies who have prolonged PDA exposure. They have this phenotype. Once the PDA gets closed by 4 or 5 weeks of life, they might end up having this dilated LALV, and it goes on to have this phenotype of post-capillary. So these were the three phenotypes, three set of infants we see at increased risk of post-capillary PH.
Great. I think we still have our second case presentation with our panelists and our junior faculty and trainees. So Laura's just putting in the chat there. So remember to go ahead and close out of this section and go into our second session there. But I just want to thank everyone again for joining, and we'll see the larger group again next month on December 3rd.
Thank you.